Welcome to the third of our four-part special series focused on obesity. I'm your host, Dr. Neil Skolnik, professor of family and community medicine at the Sidney Kimmel Medical College of Thomas Jefferson University. This special edition of Diabetes Core Update is a collaborative project of the American Diabetes Association and the American Academy of Family Physicians and is sponsored by Novo Nordisk and Lilly. Obesity is a common and important health issue. Now, notice I said health issue, and that's for a reason. On the first podcast of this series, we talked about the epidemiology of obesity, how obesity doesn't affect all populations equally, and most importantly, our current understanding that obesity is a chronic disease. It is a health issue. It leads to all sorts of downstream consequences. We also discussed some of the hypotheses explaining why obesity has increased as it has over the last 50 years. In our second episode, we did a deep dive on the treatment of obesity. We talked about lifestyle management, medical management, surgical treatments. Today, we're going to talk about something a lot of us don't like to talk about, which is how to open up the conversation about weight management and obesity. It's a sensitive topic for many of our patients, and we, being sensitive physicians, often find it difficult to bring up. If we're honest about it, we would be asking each other for help, but let's face it, when we're attending physicians, it is hard sometimes to say that you need help about how to talk to patients. So joining us to accomplish this really critically important task, we have both seasoned physician experts and also one family medicine resident, because the wonder of being a resident is you're not afraid to ask questions. Juliana Carvajal is a third-year family medicine resident at Abington Jefferson Health in Abington, PA. Welcome, Juliana.
Hey, Neil. Excited to be here. Thanks for having me.
And Dr. Susan Fidler is Associate Director of the Family Medicine Residency Program at Abington Jefferson Health. Welcome, Sue.
Thanks, Neil. Happy to be here.
Dr. Charles Vega is a clinical professor of family medicine. He is director of the UC Irvine Program in Medical Education for the Latino community and associate dean in the School of Medicine at the University of California, Irvine. Chuck, it is an absolute pleasure to have you on the podcast again.
Yeah, likewise, but I was really hoping I'd be one of those young and up-and-coming physicians, but maybe that's a couple decades past now.
Oh, gosh, and I invited you because I thought you were one of them. And finally, Dr. Margot Savoy, who is Senior Vice President for Education, Inclusiveness, and Physician Well-Being, a critically important set of topics at the American Academy of Family Physicians. Welcome, Margot.
Hi, everybody. Really glad to be here.
Juliana, I'm going to start with you and by asking you a question. And the reason we're starting with you, as we said, is attending physicians have sometimes a little bit of hesitancy, acknowledging that they're uncomfortable bringing up weight management and obesity with their patients. But we know from individual conversations with clinicians, this is often an awkward area. It's an area where people are uncomfortable. And Juliana, when we were working together about a month ago in obesity clinic, weight management clinic, you asked me about something that I didn't even think to cover when we were talking about the treatment of obesity. Can you share that with us?
Yeah, so while Neil and I were on obesity clinic, I found myself asking him on tips on how to actually broach the topic of weight and obesity in general. I think as a family physician and primary care in general, it's such an important topic to discuss with our patients. But I personally find it so uncomfortable at times to discuss since it's such a sensitive topic for a lot of our patients.
And Juliana, can I ask you, when you say you feel uncomfortable, is there anything particular you are concerned about when you address this?
Yeah, I think the biggest concern is really making the patient feel like I'm trying to make them feel bad about their weight. And if I say it in a way that does not make them feel good about themselves, I don't want to ruin that patient-physician connection. So it's definitely a sensitive topic.
That's so important. I'm glad you framed it that way because we always want to be sensitive to patients' needs and we want to leave the door open for them to come back to talk with us about things that are important. Sue, can I ask you your ideas about how do you open the conversation about weight management with patients?
Sure. And I think it's fair to start saying that this has changed in my practice a ton in the past couple of years. More often than not, people are actually coming to me asking to talk about their weight, which is really unique for my experience in the past few years. And I think it's a little bit about the medications, a little bit about the publicity of weight management, and the fact that obesity being recognized as a chronic disease has really opened up a lot of doors for patients to talk to us. I usually will start to see if the conversation flows from other areas. So often at our visits, whether it be a routine physical, if someone's there with diabetes or high blood pressure or mood disorders, we often ask about people's eating habits and their physical activity. And lots of times when we ask about this can be a doorway to opening that conversation with patients. It helps to set it up in the way of why are we concerned about weight? What are things that we want to talk about with weight? And I like to lay that foundation to see if people open that door for a conversation. Sometimes, though, when we open that door, we have to be careful about asking about whether they want to talk about it more. And one of the ways I like to approach that, one, when we talk about eating habits or physical activity, is say, do you have any goals around your eating habits or your physical activity that I can help you with or that you'd like to talk about today? And again, I think that gives them some control in allowing me to participate and be a partner with them into where they see themselves going with their health journey. And sometimes this doesn't come up, right? Sometimes eating habits, physical activity doesn't come up in a conversation, but it often can be a visit about something that is related to their weight. Things like sleep apnea, some musculoskeletal concerns, all can be tied in part to someone's weight. And if, again, we haven't had this moment to delve into it, I will often just be frank and say, would it be okay to talk about your weight today? And just leave that and see how they respond to that and take it from there.
I love that, Sue. With a focus on health, using those other health concerns as a point of entry and asking for permission. Chuck, your thoughts. How do you approach this?
Yeah, I definitely validate everything that's been said so far, Juliana. You're right to have some trepidation because many patients have experienced bias and stigma at the hands of healthcare professionals where they should have that trusting relationship. And they carry that with them forward into the encounter with you. And so I always want to be very mindful that it is a sensitive area. I watch the patient not just for what they're telling me, but their body language can indicate just how much shame or how painful a subject this is. When I've asked permission, Sue, that's a great point. Asking permission, this is definitely one of those elements where you want to ask permission to discuss this. And I've had patients just start crying spontaneously on hearing the question. And that's going to tell me, okay, we need to slow down and unpack this at the patient's own pace and let them tell their story. I think it's really important. If you want to make a difference in the sleep apnea and the diabetes, heck, in the osteoarthritis or the risk of cancer, you've got to go upstream and start working on some of those upstream issues. Obesity is being a major one of those issues. And to get there, it does take a little extra time. So I don't put it, I would not necessarily have the conversation in somebody who's in a real hurry and just wants their knee osteoarthritis treated or their upper respiratory infection. But developing continuity and trust over time is really important. And usually by that third or fourth visit, I find we've got that window. Let's go ahead and take advantage of it, as you so eloquently described how to initiate that conversation. Thanks.
That's fantastic, Chuck. Margot, it looks like you might have something to say.
I was just getting super excited because you guys started with the part that I think is probably the most important thing that could come out of this podcast. And it's just the idea of being open to asking for consent for something that seems like a conversation we think that we have the right to have. And so we think that because we do the vital signs that we have the right to just launch into everything that's in those vital signs. And this is one that it's not even just about obesity. It's about weight management in general, because sometimes it's the other side of weight management where people are having struggles with eating disorders and other issues. And you launching into that conversation about weight without allowing them the moment to get themselves together, just derails the whole conversation and maybe derails your relationship. And so I love the fact that you just went right there from the beginning, really being respectful of the patient space. I just think that's so awesome.
And Margot, I love the fact that you brought up eating disorders, which is something that probably has not been given the attention that it deserves, as we're spending a lot of time focusing on weight. There are many people who equally or even more so struggle, as you said, with the other aspects of eating that are critically important for them. I'd like to now ask our experienced physicians what your experience usually is once you open the topic, because as Juliana said, we're sometimes afraid to go there, but once we do, Chuck, your experience?
I go where the patient takes me, and I use a lot of open-ended questions. I feel like it doesn't take that much longer than using closed-ended questions, but it certainly gets me a lot more wonderful information. Finding out about their journey, how they feel about their weight, certainly what's been tried in the past, what's worked, what hasn't, how recent that was. Do they have any chronic illnesses related to obesity? Because we really want to frame obesity as a health issue. Patients may be motivated by a bunch of different things. And I think that getting to that motivation, as Sue was describing, is really important. But some of those things may be more cosmetic. I've got a wedding to go to in 6 months. I really want to fit into a certain outfit. And that's okay, but I'm going to bring it back to the health issue. It helps normalize it for folks, and it really helps when we think about those comorbid illnesses as well. And so I think every patient is actually quite a different journey and quite a different story. The good news is, at the end of that story, we certainly, I think, have a lot more that we can do in terms of practical means to help patients with overweight and obesity versus what we used to have. And I think that, as Sue also mentioned, there's been something of a cultural revolution here. It's very that patients are more interested in some of these solutions. And that's a great place to be, starting with that kind of motivation.
Great point. Sue, what has your experience been?
Yeah, I think similar to Chuck, it's hearing everybody's stories. And I find that these first conversations around weight have a lot more listening on my part than speaking. It's really letting someone tell you what they've been through, what they've tried. It is rare, almost never, that someone will say, I haven't really done anything or tried anything or thought about it. People think about these things and do a lot of things before they come and talk to us about them. And I think the other piece that I find very interesting and I really try and listen for is people come with varying degrees of certainty and uncertainty that they can succeed. And I think there are a lot of preconceived notions that people walk in with on whether or not they themselves can be successful. And I find that to be a really interesting thing to talk to patients about. Because again, that piece of it really will help inform how you tackle the rest of it.
It's really interesting. I've found, we've mentioned obesity is a chronic disease, and Sue, you bring up many people don't feel they're going to be successful. And I've been struck that people often have a sense of either failure or shame from repeated attempts at weight loss that are often initially successful. And then, as we know, you regain the weight. And Chuck, you earlier mentioned about people crying when they finally talk about the topic. I've often had people cry as I explain to them that this is a chronic disease, that it isn't their fault, that the reason they regained the weight, the reason they haven't been long-term successful in the past is because of the fact that obesity is a chronic disease, that there are these hormonal shifts that occur when you lose weight. There's metabolic adaptation. Your basal metabolic rate slows down. So on those same calorie deficits that initially allowed you to lose weight, you now plateau off and even begin to regain the weight. And it just seems to explain so much. And Sue, as you've alluded to, for people who feel they have failed at their weight loss attempts in the past, they feel more hopeful now. And then as we go forward and talk about other approaches, in addition to lifestyle, whether it's medications or bariatric surgery, they feel more either enthused or motivated to move forward. Margot, any thoughts you have at this point?
I just really agree. I think that self-efficacy piece is really important Because as a person who has tried and lost weight successfully many times, only to have to do that all over again, there is a part where I think people start to think there must be something wrong with them. And perhaps you might be the first person who could tell them that there's not something wrong with you. You're just working on an uphill battle, and it's a challenge, and this is an ongoing challenge. And we've got tools, and these are the tools that can help you. And you might be the first person to say it in a way that makes them feel seen, makes them not feel abnormal. And I think Chuck said it early, just normalizing the fact that it's a conversation and it's a thing that we're going to work on together, just like we work on your blood pressure and we work on your arthritis. We're going to work on this. But knowing that you have a partner in that journey, I think is just really helpful, because I do think a lot of people carry shame.
I think you're right. Chuck, let me ask the next question to you. Now, we talked about a lot more people now are willing to talk about their weight, or willing to move forward with attempts to manage their weight, but not everybody. And when you talk to someone and they're not sure they want to move forward to address overweight or obesity, how do you handle that?
Yeah, that's a great point. It definitely happens. And when you, just by asking permission, sometimes you're going to hear, no, I don't really want to talk about that. I will usually let it go. And I fall back on the one superpower we have in primary care, which is continuity, and maybe trust. The trust may be like the actual cape or whatever that we have. But because it starts with continuity and developing a relationship over time. And when they say no, and usually they're polite, just no, I'm just really here for my diabetes today. I'm really here just for this headache. It's driving me crazy. It's okay. I say, okay. That's fine. And we're going to work on the headache in a minute. I really think that it is important, though, to think about your body weight. It may be contributing to some of the illnesses that you have. And so I think it's worthwhile to have that conversation. Is it okay if we bring this up at another visit? And inevitably, the answer is yes. There's some people who really have, when I hear the stories eventually at that third visit, just how poorly they were treated, where somebody was yelling at them and blaming them for their obesity and giving them no solutions as to how to go about remedying that situation, I understand a lot more about why it's so difficult to talk about this. And again, just it goes back to having an empathetic tone and hopefully not just you, but your entire staff and practice is oriented to providing very patient-centered care for this important disease state.
We often also talk about just that classic motivational interviewing. You're here for blood pressure, as Sue talked about, the cholesterol, and would you like to talk about weight because it affects these other things? There are downstream consequences, and it's always about giving people options and letting them, Chuck, as you said, opt in or out. I love your concept of our superpowers. I want to shift our discussion a little bit to options. Remember, the options are now really lifestyle, medication, and bariatric surgery. And we know that lifestyle has the challenges inherent to completing diet and exercise, and in the best of hands, the best programs. And we had Dr. Tom Wadden talk about this during our last podcast. You get 5 to 7% weight loss, and it's hard to sustain that weight loss. We have medications, and there's very specific indications. It's not everyone. The indications are a BMI of 27 to 29.9 with at least one obesity-related comorbidity, or a BMI greater than or equal to 30. And our experience with medications, particularly semaglutide and tirzepatide, is much different than lifestyle. We get, on the average, 15 to a little over 20% weight loss. And then we have bariatric surgery. And it was only a little over a year ago that the American Society for Metabolic and Bariatric Surgery, and they published this in December of 22, updated guidelines for bariatric surgery that had actually not been updated since the NIH guidelines in 1991. And essentially, the new guidelines say that bariatric surgery should be considered as a treatment option for patients with metabolic disease and class 1 obesity, that's a BMI 30 to 34.9, who do not achieve substantial or durable weight loss or comorbidity improvement with non-surgical methods. And they go on to say that it's recommended a trial in non-surgical therapy is attempted before considering surgery. And then, though, in class 2 obesity, a BMI greater than or equal to 35, they specifically say that metabolic and bariatric surgery should be strongly recommended in these patients, regardless of obesity-related comorbidities. Though they said that in the context, remember, this guideline was developed over a year prior to publication, really before we had a lot of experience with our current anti-obesity medications. And it's always important to put things in a context. Remember, with bariatric surgery, you get from 25% weight loss to a little over 30, maybe up to 35% weight loss. So we have this spectrum of weight loss that in essence, our patients can choose between. Sue, I'm wondering how you handle this wide array of options that we now have.
Yeah, I guess it's a blessing, right? For a long time, we didn't have quite as many options. And I think it has a lot to do with where the patient is in their journey so far, right? Once we get that story of what they've tried, if they've spent a lot of time optimizing their lifestyle, their physical activity, their eating habits, then I think that conversation about other means, so medications and surgery, becomes really important in that next tier. We don't want to keep asking someone to do the same thing over and over again that isn't working for them. And we know that in the chronic disease model, some patients need further treatment. And then I guess it's a little bit about patient preference and how much weight they desire to lose and that you hope to help them lose, right? And that's a very value-driven decision based on what the patient wants. And exactly how you just phrased it, right? Giving them a sense of how much they're going to lose with the different measures, what it entails, what are the risks and benefits of the medicine? Because again, they have risks associated with them as well. What are the risks and benefits of surgery? And having that conversation with them to see where their values lie. Again, this is so individualized, which I think as family doctors, like we really love. We love meeting someone where they're at and figuring out what's important to them and then helping them decide and make some decisions and being there to partner with them.
I keep thinking that's what's going to save us from AI taking over, our ability to listen and then to individualize. Chuck, any thoughts you have about how to discuss options?
Yeah, I think that Sue did a great job of discussing those options, and I try to. I just don't want to forget lifestyle changes. That's at the core and the bedrock. Now, certainly through medications or surgery, that's an accelerant, and we should see success even in those recalcitrant cases where they've really struggled with this for years. But core to that is those lifestyle changes. I've had patients who actually stopped their GLP-1 receptor agonist. But because they had so many dietary modifications during the 1 or 2 months when they took it, they continued to lose weight even after discontinuing the drug to a pretty profound extent, like up to 10% weight loss, where really it started having a disease modifying effect. So remarkable things, and just don't want to forget about those basics as you move forward. And part of that, I think, Margot, you were talking about patient agency and just having the power to make these changes. This can be an incredibly empowering thing. And lo and behold, once you get to see some success with body weight, maybe quitting smoking becomes more of a possibility, or more regular exercise, following up on those vaccinations, you see a whole profile of things that could start to happen. And it starts based on your relationship with the patient.
Critically important points. Margot, I'm going to turn to you now. You're Senior Vice President, Education and Inclusiveness at AAFP. Can you share some thoughts about stigma, bias, and social determinants of health in the care of people with obesity? And also, particularly, I want to make this really practical with attention to how our understanding of this can inform our approach in the office.
Of course. It always strikes me, like, we think about bias and stigma and people automatically jump to certain things, and they don't really think about weight as being one of the things that can be pretty stigmatizing. There's pretty clear studies that people even make less money and don't get jobs because of their weight. So there's just things that are true about us as a society that just add to the burden and the barrier that people may be carrying as they're coming into your exam room. For me, the part that really struck me and really hurt my heart is that we create some of those challenges when people are trying to access care for us too. And the idea that there's been now multiple studies that they've shown that overweight and obese patients, particularly those who identify as women, will actually avoid coming to the doctor or avoid getting care or skip really critical care. So things like pap smears because they're afraid that they're going to be shamed about their weight. They're afraid that whatever problem they want to come and tell us about, we're going to attribute only to their weight, but we won't really listen to anything else that they're saying. It's just all about your weight. And the idea that we're contributing to that just really hurts my heart. And I don't know that people are doing it trying to be bad or trying to be mean or hurtful. I think they really do think that weight creates a lot of issues and that obesity is driving disease, because we know that obesity does drive disease, and that it does increase your risk of cancer, and it does increase your risk of cardiometabolic issues. But the idea that you're not giving them the chance to tell their story and to help them understand what it means to them in their life is just really harmful. And it's why I'm so glad that we're having this conversation today. And I'm hoping that people really take to heart the advice that they've been given up until now. One of the things that has come up repeatedly is that we've often lost this battle before we even tried to have the conversation, so that you have to set the stage to be prepared to talk about something that could be stigmatizing for a person by making your place feel welcoming. And if you walk into an exam room and there's no chair where you can feel like you can fit safely, or where you feel like when you sit on the chair is going to allow you to stand up or sit back down in a way that's with ease, if you expect the person to get their weight taken in the middle of a crowded hallway, if you're expecting them to wait for you to go get the quote unquote big girl cuff to do the blood pressure, or if you've got to go find the gown that fits them in the other room, which just is othering behavior, right? So it's just making people feel like there's something wrong with you. It's so wrong with you that I got to go get the other thing from the other room just to be able to do basic normal things with you. That sets a stage for a person to already not feel good, to already not feel safe. And if they don't feel good or safe, when you finally get to the part where you want to invite them to that conversation, they're much more likely to tell you no or to not feel comfortable. And so these are things that you could do something about. So on one hand, it's depressing because it's like, oh my gosh, I never really thought about that in my waiting room. That's something you can actually take action on tomorrow. Like you can walk out in your practice and look for places and spaces where you could just be better. Moving the scale to a private room seems so small, and yet it could be life-changing for someone who just isn't comfortable stepping on that scale otherwise. And then making sure that you have access to an opportunity to have things like the cuffs and the gowns and the other issues that you need physically in the rooms where you're at is something that you can control. We often think about these as things that somebody else decides, but you as the clinician actually can decide some of the things that are going in those rooms, and you can make that easier for yourself. The other thing that we hear a lot is that words matter. So you can also lose the battle if you're not thinking about the words that you're choosing. And sometimes it's the words that we choose on purpose because of medical stuff. So we've been talking about obesity this whole time. It turns out that when you label a person morbidly obese or obese, you might completely turn them off of the conversation. And so as you're asking for consent to have the discussion, you might want to ask them how they want to talk about it, so that in medical land, we talk about obesity and morbid obesity, and it has these numbers that are associated with it. How does it make you feel, and how do you want to talk about it? It's something you could ask. And this idea about really being thoughtful about the words that you use, how you're using them with the patient, that you're not implying things that you don't mean to, and that your implicit bias isn't coming out by accident, I think is something where we can reflect back on and really be thoughtful about how maybe we got shut down in a conversation. Sometimes it's something that we said and that we weren't necessarily intending, but what we said really did hurt and cause a problem. And then the final thing that I just flag for people, because I hear it sometimes whenever we talk about DEI issues as it relates to a person's health, you hear this thing, certain cultures just value being overweight and obese. And I'm like, I've never met a culture where they thought, gosh, I really want to be unhealthy and live less years of life. It's not what people are saying to you. Normally what you're hearing is that people have different cultural attachments to things that might drive you to have obesity or overweight, right? So if food comes with a different value to you, and it's a way of expressing love or expressing care, then the idea that you're not going to eat the food that was prepared for you by somebody who cares about you really creates a different conversation. And you've got to be open to have that discussion and have that conversation. Or if in your family, everyone is a certain size and you suddenly start losing weight, they're going to think you're sick. And they might be very concerned about you and actually try to feed you to make sure that you're going to gain the weight back. And so having those kinds of conversations, where I think these are things family docs do extraordinarily well. The family, and you know how people think and talk in that group, and you can bring up to them, hey, sometimes in families, this could be a weird thing. If you got to go to Thanksgiving dinner and you're the only one with the little plate, how's that going to feel? What can we do with that? How can we talk about that ahead of time? So these are usually cultural things, but they're not cultural the way that sometimes I hear people talk about it. And so I just flag it because remember, you're putting them on this healthy lifestyle. It's not just about the weight. It's actually about them having a lifestyle that helps them be healthier, so they can achieve the goals that they want in life. And so this is a lifetime commitment that they're going on. And so they're going to need to be able to figure out how to navigate those birthday parties and those happy events with their family. And you being able to talk to them about it brings it back to home, because it's not just about my weight or my size. It's about me as a person and how I relate to my family. And that really changes the conversation. It makes it much easier for you to get where you're trying to go with the patients.
Margot, I just sit here absorbing when I listen to you talk. I am so glad you're part of our conversation today. We're almost out of time now, and so it's time for all of us to put together some final thoughts. And Sue, do you want to start?
Sure. Yeah. This has become something I've really enjoyed doing in practice. And I think there's a couple of reasons. I think that it's about someone's story more so than a lot of things we do, and really understanding where they're coming from and what their journey has been up until this point and how I can help them moving forward. It's a great way to be involved in people's lives. And now we have so many more options, so many things that we can use to help people. And at the end of the day, I think all of us are just trying to help people. And I think if we convey that to our patients, that we're there, we have the best of intentions. And if we use words and phrases and questions that make them feel like they matter, we're going to be able to partner with them and help them moving forward.
Thanks so much. Chuck, your final thoughts.
Yeah, that's outstanding. Thank you. I think that I went into primary care with the idea of preventing disease and preventing disability and prolonging people's lives and having them achieve their goals and helping them along the way, every step of the way. And I do think we do have more tools now than ever. And I really appreciate this revolution that's going on in the care of overweight and obesity, because I know that down the line, certainly there'll be a lot of great public health outcomes, particularly for those communities where they need it most, I hope. But also it is those individual stories. It's the individual folks who can play with their pets again, who can go to the park with their kids or grandkids, who can walk through the store and do so with confidence and feeling healthy. And that's really outstanding. Wherever the wins are, we're all about the wins. And the wins really come from the patient. So that keeps me going every single day in clinical care.
Beautiful. Margot, your thoughts?
I really think Sue hit the nail on the head about words really do matter. The words that we choose, the words that we say make a difference every single day. And in weight, it's really important, and it makes a difference in people's ability to receive the help that you want to give, because I know you're doing it from a place that's coming with love and trying to be supportive and helpful. You don't want to trip it up by choosing the wrong words. And so approaching your conversations with what I like to think about as respectful curiosity. So you're being truly curious about their story and wanting to know more about them, but with all respect, like with true respect, just really understanding that their journey is their journey and you're just a passenger for this part of it, trying to help them get where they're trying to go. And so that means that you've got to be a little bit mindful and on the lookout for your implicit biases and where they may show up and cause you to do things that you didn't mean to do because they're just getting in the way of this journey that you wanted to go on with the patient.
Beautiful. Yeah, I've heard all these great themes today. Words matter, the way we handle things, sensitivity to people, the importance of addressing the health aspects of weight management, sensitivity to people who may have eating disorders, the fact that we have this opportunity now, an incredible opportunity to affect things, and the term that was used, I believe, Chuck, you mentioned upstream, that because we know that obesity is often the soil out of which so many things like hypercholesterolemia, hypertriglyceridemia, diabetes, sleep apnea, metabolic liver disease, on, out of which that grows. And for the first time, we have really effective interventions. But Sue, as you said, wonderful options. It's incredible that we have that opportunity now, and we had the ability, Chuck, you said it great, to use our superpowers. It's continuity and trust that allows us to talk with patients, and Juliana, as you open for us, and open that conversation that is sometimes difficult, but such an important responsibility to have. Doctors Juliana Carvajal, Sue Fidler, Chuck Vega, Margot Savoy, thank you so much for joining us. And most importantly, of course, to our listeners, thank you for joining us on this third of our 4-part series on obesity. sponsored by Novo Nordisk and Lilly. If you haven't listened to the first and second episodes, let me tell you something. They are really good, as I believe this one was as well. And we look forward to you joining us for the fourth part of this series, where we're going to focus on challenges in weight management, as well as potential solutions in the identification and treatment of overweight and obesity for the American Diabetes Association and the Academy of Family Physicians. I'm Dr. Neil Skolnik. Till next time, stay safe and keep learning.